Next we will go to the lateral decubitus view. As you see in the image, patient will be in the one side, it will be lying down in the one side, lateral side. Usually left side will be touched on the cassette, right side will be in the up. Why, you might be thinking, because always when you take, this should be taken in this positioning only. So always left side should be down. So if it is suspected with the perforation, what will be there? There will be leakage of the bowel gas. So if it is taking right lateral, right side will be down, so left side will be up. So there will be confusion with the it is that bowel gas, it is there in the stomach or it is outside the stomach. If left side is down, means left side is consists of the stomach, right? Stomach will come down. If it is anything air it is there, means it will, if it is leakaged air it is there, means it will come to the right side, near to the liver and all. If it is near to the liver, any gas it is present, means it means there will be a perforation, leakage of the bowel gas. So that's why always should take left lateral decubitus view whenever you are taking abdominal radiography. So what is the positioning? I already told you, patient will be lying down in left side down and the right side is up. The mid axillary line will be perpendicular to the table, or mid sagittal line parallel to the table. So knee will be partially flexed so that patient will be comfortable to lying down in that positioning. Arm should be upper near, should be kept at the under the head. One left will be under the head, right arm will be above the head. Will be flexed to avoid the overlap on the abdomen. So where is the centering ray? That's 2 inches above the iliac crest, between the two iliac crest. So adjust the height of the cassette so that the mid sagittal plane will be a perpendicular to the cassette center also. So that should be necessary when it's taking patient this in a decubitus view. Then what is the technical factor? SID in the, or FFD is called, where is 100 centimeter, 50 to 60 kVp, MAS will be 90 to 100 MAS will be given for the adult patient. So what are the structure you are going to see? Stomach, bowel, segments, bilateral, diaphragms and all. So here you can see with the image, you can see usually stomach is come here. If this gas, we don't know it is in the stomach or it is in the bowel or thing. So if right lateral, if you are taking, this stomach will come here, so that if you can see whatever the leakage gases are there. See here you can see this is the leakage gases, this is the liver. Due to the perforation or any might be the any reason. See here you can see pneumoperitoneum. This is all. So this is all bowel, large bowel gases. So this is the peritoneum cavity. So this is the ribs. So this is the liver border. So it means when the air is present here, means there will be 100% definition thinking that there is a perforation. So what is the evaluation criteria? No rotation of the pelvis, no motion should be there, optimum density and contrast should be there. Next view is the AP erect view. It will be upright positioning. Erect view in the sense patient can be in a standing or patient can be in a sitting positioning. So what are the positioning? So patient will be in a standing positioning. You can see both the arm will be kept away from the abdomen area. Okay, and cassette, upper border of the cassette. See, this is the upper border. This is the bucky. Usually the upper border of the cassette will be at the episternum level, so that both the diaphragm, dome of the diaphragm will be included. So remember, when you take a AP erect view, you should include abdomen, upper border of the dome of the diaphragm. If you are not included dome of the diaphragm, means you have to repeat the radiography. So erect view will be usually it will taken to see air fluid level, air or fluid level, so that when patient is standing, what will happen? The air, everything will come up and stay under the dome of the diaphragm. If it is that not included, means you have to repeat the radiography. So remember that. So again here mid sagittal line will be perpendicular. Again centering ray just 2 inches above the iliac crest. That will be done. Again here 17-14 cassette will be used, and 50 to 60 kVp will be used, 90 to 100 ms will be used. So what are the part you're going to see? Structure shown: stomach, bowel gas, bilateral diaphragm. It should be seen. See, now here you can see this is the diaphragm. You can see white line. This is the diaphragm. Above that lung, the below that is the abdomen. Here also at the left side. So now you see this is the diaphragm. Below that, whatever, if you dark, you can see this is the air, this is the liver, and this is the, it means pneumoperitoneum. It might be something suspecting perforation or any pathology. That's the reason. You can see left side, you can see this is the, here also at the level, here also some air level. Maybe this is maybe and inside the stomach, maybe outside the stomach, we cannot make out. So that's why always right side is very important to include even in decubitus view. So no rotation of the pelvis, no motion, optimum density and contrast should be there. That is the evaluation criteria. So sometimes dorsal decubitus view also will be taken. Is left lateral or right lateral decubitus is not possible, you cannot tilt the patient. At that moment we will take a lateral decubitus, dorsal decubitus view. Here patient will be same how you do the positioning of the supine positioning. That same positioning you will do. Only thing, cassette will be kept at the left side of the patient or right side, any side can be kept. So this is left lateral decubitus, and radiation which is X-ray will be exposing from the right side to left side. Here there will be no question of you can keep the cassette right side or left side, because no issues, no problem. Only when you take lateral decubitus, that time you have to take a left lateral decubitus. So this is also, if it is any, this is the also indications like suspected perforation, sinus, anything, pneumoperitoneum, hemoperitoneum, any such things is there, means we will take this radiography. So again, centering ray, it will be passing through the horizontal level, horizontally ray. So 2 inches above the iliac crest. Again, factors will be 50 to 60 kVp, 90 to 100 ms. What are the structure you are to see? You are going to see dome of the diaphragm. See here, this is the lateral positioning, dome of the diaphragm. This is all, as you can see here in this image, whatever the gas or leakage, any air is there, means it will go and stay at the upper border, I means anterior part of the abdomen. So that is what we are going to check it. No rotation of the pelvis, no motion, optimum density and contrast should be present when you take this or the radiography. So here you can see certain just pathology images I had included in the slides. You can see pneumoperitoneum. You can see here this is the liver. This is the right marker. You can see here under the liver some of the air is accommodating. You can see this is clearly, you can make out. It means there will be a perforation. Anything might be there, due to that pneumoperitoneum will be there. So this is the another indication. You can see such a large bowel here. You can see. So this is one of the indication. Here also you can make out with this all white. What you can see, this is the barium, large intestine barium study, barium enema we call. This all barium is injected through the anus. So large bowel, this is a sigmoid colon, this is the anus, and this is the descending colon, this is the ascending colon. See, ascending colon is so large, it means there will be a distension of bowel gas. Thank you so much, and please go through that views. It's one of the important topic. Read it. Good luck.